And it's two EHR systems that are very, very well-known systems, right? I won't name the vendors, but they're very well-known systems. All of you have heard of these systems. And then we went in and did a survey, because it's for a patient-centered medical home project, wanted to know how many of them could deliver data. And they're both mature. They've been up and running for years. How many of them could deliver data to support a patient-centered medical home project specifically focused on diabetes? So this wasn't even across the board. It was just diabetes. You would imagine that in primary care, that's what these guys are focused on. None of them can report any of the data that we need. 0 out of 50. In Massachusetts, we're doing some work for a PHO where they asked us to come in and provide what we call rescue services, which is basically EHRs that are already implemented and broken. Roughly 250 physicians there, about 75 of them were live on EHRs. The PHO's team went in independently to audit those practices that were on 4 vendor systems to find out how many of them could deliver quality data. I'm a little bit distressed to report that there were only 2 practices out of the 75 that could. I'm proud to report that the two practices who could were the practices that were implemented by the Mass eHealth Collaborative, who happened to be members of that PHO. It's not that we're geniuses, it's because we had resources and we paid attention to it. And I think that's a little bit of the flaw of the way HITECH is structured, that right now it doesn't provide resources for organizations that could do it and doesn't give them enough sort of wherewithal to pay attention to it. The concern I have is that, and so I talked about truisms. I'd like to talk about truthiness, to quote Stephen Colbert. That I think that there is a sense right now that giving dollars directly to physicians is going to unleash the huge winds of innovation that are going to fill the sails of healthcare reform and get us to this promised land where we're not spending more for less than any industrialized country in the world. And the reality, I think, is that the current course is a little bit disastrous. Although I am confident that it's going to fix itself. I just would like that to happen sooner rather than later. So the problem, in my view, is that the HITECH has a lot of really good pieces, but they're not connected. So there's no sort of overall perspective on how all of these fit together and work together to solve the problem of HIT adoption, which is EHR, HIE to transform healthcare, right? Which I hope all of us agree is what we're trying to do here, and that they're not funded in the right proportions. There's not enough programmatic structure to oversee this, I would argue. So we've started off with a conversation of saying, oh, it's $19 billion, right? And there was a lot of confusion around that. It's $35 billion with $2 billion of programmatic overstructure, structure on top of it. Now the new number is actually $46 billion. For those of you who are tracking the reports that came out last week that ONC and CMS submitted to the Congress, it's roughly $46 billion that we're going to be spending on HIT incentives, still with only $2 billion on top. I mean, I can't think of a business that would operate that way, that would keep saying the program is bigger and bigger and bigger, but we're going to keep the same thin programmatic overstructure to make sure that those dollars are spent responsibly and oriented toward the goals that we need. So to me, the last point here is that the small practice adoption challenge is really twofold, and I would just try to lay it out as simply as I can. One is about giving a clear set of transformative goals. What is it that we want them to accomplish? And the second is providing an infrastructure to facilitate that transformation. And right now, I think the current approach really runs the risk of doing neither, because meaningful use is, I think, going to end up having to be watered down so much that it's not going to really have a whole lot of traction because we don't have the infrastructure, to make it broadly applicable. So we're going to end up having to, get forced to the lowest common denominator. And as I pointed out, we don't have the infrastructure to facilitate that transformation. So basically, how do we tell small practices what is it they need to do to get to the next stage of healthcare, and then how is it they can do it, and where are the resources for to get them to do it? I mean, if it was so easy to do, they would have done it already. So just in closing, I mean, my solutions would be, first, setting the bar high. That we need to set the bar high on meaningful use, and to really set the bar high on transforming healthcare to get us to the next stage of where we want to be. That would include having to make some policy changes. And one, I think, would be about connecting these regional health IT extension centers with the incentive dollars. So there's a lot of incentive dollars. As I said, $45 billion in incentive dollars, with a very small amount of money going to the regional health IT extension centers and no connection between them. There's absolutely no connection right now in between them, which I think is just a fatal flaw in the way that this is getting approached. I would also suggest that in order to set the bar high, we're going to have to phase in, I would suggest phasing in the incentives regionally to accommodate different levels of readiness for change. Right now, the way HITECH is structured, everyone has to hit 2011 at the same time. Which, when you think about it, for even the states that are the furthest ahead, that's going to be a significant challenge. And now we're, sort of forced into this box where we're trying to say how we get everyone in the country to, to get to that bar, to get to a bar by 2011, which I just don't think makes sense and doesn't really set us up for success. So that just concludes my comments, and very much look forward to your questions in the comments. Sorry.
Thanks for this opportunity to present some observations on the deployment of information technology in small and rural practices. I wanted to mention that the answer to Micky's query about how we're going to move these so many people forward is in Bob's remarks, that 80% of the effect can be accomplished with some initial agile EHR light connectivity. So we're already hearing it, and I'm going to reinforce that with my remarks. My comments are made from the perspective of an information technology project manager. I work for Redwood MedNet, a nonprofit health information exchange in rural Northern California. And prior to Redwood MedNet, I worked as the chief technology officer for a consortium of community of FQHCs in rural Northern California. Briefly, Redwood MedNet, which was funded in 2004, began production delivery of electronic results from our first hospital laboratory in 2008, last year in April of 2008. We currently deliver results from 2 laboratories to dozens of providers, and we're pilot testing results delivery from 3 more hospital laboratories, which we hope to take into production soon. Last month we began a standalone e-prescribing pilot, and this month we expect to launch the pilot delivery of radiology reports across the network and to publicly demonstrate the newly released NHIN Connect Gateway. In other words, we're a community network, and our primary service is operating agile on-the-fly interfaces between EHRs and other health data systems. So I'm just going to make a few points in kind of random sequence. The migration from paper to digital clinical charting is a good thing. It's not a question of if, but when. However, given the plethora of current EHR software titles and the likelihood of substantial health IT vendor consolidation in the near future, the ferment of new technologies for acquisition, storage, and sharing of data, and the lack of standardized clinical terminologies, we run the risk of premature adoption of primitive data silos that will be cumbersome to retrofit in the future. For example, one of the EHRs that Redwood MedNet flows data into is incapable of correctly handling preliminary, final, and amended lab results. Specifically, these results are treated as separate tests, which clutter up the record and annoy the provider, who finally requested that no preliminary results be loaded into his EHR. So we deliver the preliminary results and amended results to his printer, which is a hassle inserted into the business process by the local EHR functionality gap. And this is typical of the kinds of things you encounter as you try to connect A to B. Micky recently circulated a really excellent critique of the 5-year EHR reimbursement incentives, and his analysis showed that the typical provider who qualifies for the maximum Medicare reimbursement of $44,000 will be out $21,000 in unrecoverable costs at the end of 5 years. And he reminds us that we can quibble over the exact dollar amount, but the important point is that it is not zero and it is a net loss to the provider. My point in mentioning this is to ask what percentage of providers will choose to sit out this round of EHR adoption incentives, and when the penalties begin in 2015, will these late adopters be better off than their peers who adopted early? Redwood MedNet recently surveyed local physicians and mid-levels on their use of technology and their attitudes towards EHR. Responses were received from 49 providers out of the 208 practicing providers in our 5,000 square mile rural region. 8 respondents, or 16%, already use EHR. However, only 3 of the installed EHRs, or 6%, import electronic lab results. This EHR automation gap is consistent with the DesRochers survey published last year in the New England Journal of Medicine. The startling change from the earlier local surveys by Redwood MedNet however, is that this year 16 providers, or 30% of the local cohort, plan to adopt EHR within the next 2 years. If this happens, the local adoption among small practices in our neighborhood will surge to 49%. If we've got a 30% failure rate, though, that could be a little bump in the road. But the point is there's still a large amount of frustration among the survey respondents. So in response to the question, are EHRs ready for widespread adoption, the following comments were received. 1, it depends on the specialty. Mine is not ready. 2, they're cumbersome to use and not reliable. 3, there are too many vendors. I'm waiting for marketplace consolidation. 4, infrastructure is not ready to support my EHR. 5, they're too intrusive in the patient-doctor interview. 6, there's a lack of uniformity and cross-platform capability. 7, they're too time-consuming to use. That was from a surgeon. 8, more rapid data entry methods are needed. 9, they're canned and obfuscate relevant data. Now, these negative comments are important because they were submitted by the 50% of those survey respondents who do not currently use an EHR and do not plan to install an EHR. It shows a strong pushback from small providers despite the subsidies and the high-profile policy imperatives to adopt EHR by 2014. It also raises the question of premature optimization in our current push into EHRs. Some of HRSA's health center controlled network disbursements look like a new version of legacy health IT silos we're now seeking to break open. In my region, these HRSA investments are creating a new digital divide between technology haves and have-nots. Specifically, some of the funding tends to be used by randomly aggregated clusters of SafeNet clinics to build new network data centers. While I admire their initiative, and while this is great employment for network consultants, as an IT manager, I'm bothered by some fundamental issues. First, I see clinics that are hundreds of miles apart spending seven-figure budgets to create a shared EHR hosting solution with no prior EHR hosting experience and without adequate planning for electronic interfaces with their major clinical trading partners who happen to be right across the parking lot or across the street, such as labs, pharmacies, and radiology. In other words, these are stranded EHRs which lack full functionality, the kind of deployment that Blackford Middleton refers to as the level 3 investment that will raise the cost of healthcare without delivering the benefits of clinical decision support and patient-centered care. Among the clinics that seek to build interfaces, most build one-off interfaces rather than leveraging community data exchange services, exactly what Bob was talking about. This is an expensive and unsustainable approach to interoperability that will in the long run be abandoned in favor of a more agile network-centered interface topology. In my region, I also see half of the clinics, community clinics, sitting out the current rush to build these HRSA health center controlled networks. As a group, they tend to be more tech savvy, so I believe their current trajectory will serve them well. Redwood MedNet works with both sets of clinics, and as a general observation, the new HRSA technology ghettos are less efficient than the standalone facilities. The best indicator of EHR adoption in my region is the level of health IT staffing in each facility. As the tech staffing level approaches zero, the likelihood of EHR adoption approaches zero. This is both a workforce and an infrastructure issue for rural and small practices. It's important for health policy leaders to understand that standard best practices for health IT in urban areas do not necessarily translate well into low-resource areas. For example, the software-as-a-service model can be a tough sell to independent facilities in remote rural areas who do not trust others with their data. A hosted service can also be unattractive in a region where broadband penetration is weak or unreliable. My final point is that rural and solo clinicians are tech savvy. Our survey shows that 94% have broadband at the office and 64% have remote access to their office networks, even though only 6% have really well implemented EHRs. One reason they're not rushing to adopt EHRs is because they see software that will increase their costs and slow down their patient care processes. As an IT manager, I don't blame them. In fact, I only encourage providers to wait because as I look across the community and imagine an agile, patient-centered health data, I see the current crop of EHRs as silos that are barriers to the free flow of data. In my view, data agility or liquidity is more important than simply installing software. Thanks for this opportunity to share some observations.
Wow. Well, fortunately, we have plenty of time for questions. I'll open up with one. So in the absence of total uniformity on clear winning strategies, let me try to drill down a little bit since there are a couple FACA committees that are trying to very quickly, meaning within hours, to come up with policies that would strengthen the case for small practices included. So Micky said that we want to set the bar high, but have a path of achieving it and a phased approach to implementing it. Bob said that 70% participating in his HIE are going to pass the meaningful criteria, whatever that is. So how do we reconcile? So what should the policy be? What is the right balance of the meaningful use threshold We know it's not zero. We know it's not 100%. What's the right balance of that threshold and the right support needed to get there, and when? Now, Micky sort of answered a lot in his, but can perhaps the rest of you reflect on that, and Micky get a second chance on how would you go about setting this bar in the way that's most supportive, realizing we can't get 100%, and that's not the right answer, and so just your reflections.